Dr. Ricciuti and Dr. Rotel with a EGFR patient that you find out has this alteration early on, say before they're about to start neoadjuvant treatment. How do I, as the oncologist and or as the patient, know which approach might be best? That being a neoadjuvant immunotherapy approach, is that an option for me as an EGFR patient and or ALK patient? Or what is your treatment strategy and who are the best patients that you would put on a neoadjuvant approach with chemoimmunotherapy?
Maybe I'll start. I think we have data from patients with EGFR mutant lung cancer who have metastatic disease that immunotherapy is not a treatment that works very well, unfortunately. We also have prospective phase 2 studies and actually randomized phase 3 studies that have shown that in general immunotherapy, a single agent, when even the PD-1 is very high, the marker that should predict response to immunotherapy, or potentially adding immunotherapy to chemotherapy in patients who have already received targeted therapy, well, that does not seem to be effective. And so that's not necessarily an approach that we would recommend for patients with EGFR mutation today with the immunotherapy that we have today. Of course, there's a question mark around what the future holds for our patients with EGFR mutation. We are rediscovering immunotherapy in some perspective for this population. We've seen data recently with new bispecific antibody, for example. There are new agents, including T-cell engager, that might potentially represent the immunotherapy of the future for the EGFR mutation. But today, the immunotherapies that are available do not necessarily work. And so actually, there is a very high chance that the tumor might progress or grow during the neoadjuvant part of the treatment. And so we wouldn't want to expose patients to a treatment that is toxic and not effective. So in general, we test our patients for EGFR mutations before we embark on any neoadjuvant approach. And today, I think for patients who have upfront, resectable lung cancer with EGFR mutation, upfront surgery remains the standard of care, followed by adjuvant chemotherapy and osimertinib, specifically for patients with stage 1B to 3A. Of course, there are questions now that the NeoAdora trial has been published and presented that is not an approach that is FDA approved yet, but I would say that off-label I've been using it because it's really been helpful to downstage the tumor with the goal of converting to surgery patients that otherwise wouldn't be candidate for an upfront surgical approach. And what we've seen in NeoAdora is that we can downstage the lymph nodes. That is a big challenge for us surgeons. And I've had patients personally who were able to undergo a surgical resection, which was successful because they were treated with a neoadjuvant approach that did include a targeted therapy, specifically osimertinib. So I think these are my initial thoughts. And I guess this extrapolating from EGFR, the same is possibly true for other drivers, not all of them, but for drivers that are commonly seen in patients who have never smoked, for example, such as ALK fusions or ROS1 fusions or RAS fusions, for instance. Those are also patients for whom I would not consider this approach, but there are patients with other drivers such as MET-exon 14 skipping mutation or BRAF mutation, from instead this could be a reasonable approach. But I also eager to hear what Dr. Otto has to add to the conversation since he's EGFR expert.
I know, I completely agree. And I think it highlights a big change for us in the field. And thinking about what matters in patient care is we need biomarkers before starting therapy in increasing numbers of patients and increasing stages of disease. For many years now, a good 5 to 10 years, we've needed these to start therapy, if at all possible, waiting to get the biomarker testing in the metastatic setting before starting treatment. It was always really hard because you've got a patient with a new diagnosis. Everyone's really eager to get started on treatment. Now you're waiting for biomarker testing so you can give people the right treatment first, not just any treatment first. And we've seen as these advances have moved into the setting of resectable or earlier stage disease, the same thing happening now in this setting. We have patients even more pressure, right? A new diagnosis, surgery is possible. There's a lot of pressure, and desire to get going as fast as possible. We don't just want to give patients any treatment. We want to give patients the right treatment, most effective treatment, the right treatment for their individual situation. And that means we really have to know their biomarkers because we need to know, are they on an immunotherapy path or are they on a targeted therapy path? So knowing that EGFR ALK status is so critical now before starting neoadjuvant therapy or preoperative therapy. And that's hard for patients. It's hard for physicians to wait, but it really is quite important right now with all the data we have.